Hey, my name is Anisha Patel and I'm obsessed with all things career development. I am a pharmacist turned entrepreneur who's transformed my passions into purpose. I've grown a podcast that has reached thousands of people across the globe. I'm building an online business and I've left my 9-to-5 to chase my dreams. I've walked this path of transformation myself, and now I'm here to share insights, strategies, and stories to help you carve out a career that you love. Career opportunities, personal development, challenges, growth, and building life skills are all things we discuss on this podcast. Be prepared to be inspired and motivated to step outside of your comfort zone. This is the Pharmacist Diaries podcast.
First and foremost, welcome to the Pharmacist Diaries podcast. Super excited that we have finally got an opportunity to connect. I have been following you for some time on LinkedIn mainly. And of course, we've both kind of found a pediatric journey. So I wanted to enjoy a conversation with someone who also loves pediatrics. And I had found you, but also Todd Uri had told me to connect with you because he thought that we would have a lot in common and that we would enjoy having a conversation together. So I said, let's do it. I'm going to contact Jenna and get her on the podcast. So I'll introduce you to my podcast. So this is Jena Quinn. She is a specialist pediatric pharmacist, and she is now also in the entrepreneurial journey. And she has a company called Perfecting Peds, which we are going to learn lots and lots about on today's episode. In terms of her background, she's definitely obviously enjoys pediatrics and medication management within the pediatric population. She's got a love for children. She has 3 little girls herself. And one of her missions is to optimize pediatric pharmacotherapy. And obviously, you've probably been focusing a lot on the US and improving things on a national scale. But there, I'm sure, is a lot of opportunity for you potentially to look outside of that and look on a global scale what's been happening. I'm super excited to learn more about your journey. So I guess let's kickstart our episode today.
Okay. It's so nice to be on the show, and I really appreciate you thinking of me. And it's another layer of really what speaks to this journey has been, so there's so much unpredictable parts, and one of them's being like, would I ever think I'd be on a podcast with somebody, other pharmacists in London? Like, how cool is this to be able to network and get to know what a fellow pediatric PharmD does in London? Because obviously I've had my visors on just thinking about the US, but as you said, people from India, Canada, Europe have asked, like, is there something that you would want to scale to our country? So again, I'm thrilled to be on, and thank you so much. I'll let you lead the question so I don't word vomit, because I could talk about pediatric and pharmacy all day long.
Well, I normally kickstart my episodes by asking you about the early days of your career and why you became a pharmacist in the first place.
Yeah, so that's a really easy one. So my grandfather, who was my mentor and really my favorite person on the earth, he was a pharmacist. And so when I wanted to do something in the medical profession, it just, to me, that was the only option because I just loved him so much, and that's what he did. I joke that he makes me look really stupid because he worked at GlaxoSmithKline, which is like a big pharma company in the US, and he had over 175 articles, 125 patents, and so he was just a really impressive, sharp guy. Actually founded that dopamine's connected to Parkinson's, him and his team here. So just lots of really cool. So it was really cool. I have on my desk, I just published my first journal article, which I'll talk about, but I actually drove down to Maryland to see my grandmom, who was married to my grandfather who passed away. And she filed it with all of his publications. And it was like a really cool, sentimental moment. And then my sister had epilepsy growing up. And so because of that, I was always drawn. And unfortunately, with the 10-year age gap, I was given Diastat, and, by 15, I was expected to know how to administer it and watch my sister. And so that really piqued my interest of medications and how they help children, and just seeing how it would abruptly abort a seizure for my sister. In addition to my grandfather, it really led me down the path of pharmacy, but then even further niche down to pediatrics.
Interesting. So your journey into pediatrics definitely stemmed way before even entering pharmacy school. And a lot of us don't necessarily find our pathway or the specialist area that we want to go into until we've started working, or we go on these, like our intern roles or placements, where we start actually experiencing what pharmacy has to offer and kind of judging where we fit into
Right.
practice. So that's a really interesting journey.
How about you? Do your listeners know how you got into peds?
My listeners may or may not know. It depends how many episodes that they listen to. I can
Okay.
100% share, and thank you for asking.
I would love that.
Yeah, so I did a short kind of 3-month rotation as a resident, and this is like super early days of me being a pharmacist. And we didn't have electronic prescribing back then. We were paper, kind of like drug charts in the hospital. And in the UK, we used to use green pens to signify that we were the pharmacist. So if you ever see green pen on a drug chart in the UK, you know that it's a pharmacist. And usually it's a purple pen for technicians. So if we make any changes to a drug chart when it's paper, you'll know that it's us.
Interesting.
We obviously sign and date that it's us as well, but
Yeah.
it's very clear that the green pen has come from pharmacy. And I did that rotation, which was 3 months long, and I absolutely loved it. But at that time, as a very junior pharmacist, I was fearful of pediatrics because it's so different to adults, and just making those adjustments to doses, and then just even signing my name against something as, I've clinically screened that, would be quite scary. So as much as I enjoyed it, I was a little bit fearful of pediatrics in the early days. But around 5 years ago, I was working in a hospital, and a friend of mine went on maternity leave, and they were struggling to find a replacement for her. So she used to cover like a couple of pediatric wards and the neonatal ICU. And she asked if there was a possibility that she could train me to then cover some of her maternity until they found a replacement. So I just started getting involved on the neonatal ward with her. And I stepped onto that ward, and it was one of those places where you step into the environment and you automatically feel at home. The connection I had with the doctors, or, in the US you call them physicians, was a different experience to what I was used to with adults. The interaction is unreal. The value that you feel from them in terms of how much support they love from pharmacy, how much they rely on us for dosing, for advice, for crushing tablets, unlicensed medicines like routes of administration. They need us all the time, and they love having you as part of the team. And if you're not around, they feel it, and they're contacting you to come back to the ward. And that sensation was something different to me. That feeling of being valued in your role, it was just a different feeling for me. And I was a mother by then. So for me, I'd already been through my first parenting journey. And so being part of the neonatal team was really interesting from a parenting point of view, because there's always parents on the ward, whether it's breastfeeding issues come up, will these medications mix with breast milk? How do we support these families? What formulas we can use? As a parent, I was also able to give some input and advice, or things that have come up in my experience as a mom. And when I mixed those two things together, I realized how much I enjoyed it. And so that kind of like sparked my interest in pediatrics. And in that role, I was hired to work as an education and training pharmacist for our interns, or what we call our trainee pharmacists. So I'm supporting pharmacists who are going from their kind of degree to becoming practicing pharmacists. They have a 1-year kind of intern role. So that was my main focus, but I supported on the neonatal unit when needed and enjoyed the experience. And when I was in that role, I was really fortunate that I found a job opportunity which mixed both education and training and pediatrics at a specialist pediatric hospital. And I thought, I don't have that much pediatric experience, but I'm going to wing it, apply for the position, and demonstrate my love, my passion, and my joy in this area of expertise, and explain to them that, hey, I may not know everything now. I may not be the expert that you would like, but I'm willing to put in the work to become the expert that you need. I'm willing to learn at a fast pace. I'm willing to put in all the effort and energy that it takes. I need a little bit of support along the journey because they were expecting quite a senior pharmacist, but all the skills that I had in leadership, in education and training, in project management, my personality, all of those fit the criteria that they needed and more. And I just needed a little bit of support from the clinical perspective to grow as a specialist pharmacist in pediatrics. And I was able to get that position. So the job was split between sort of 2 days working at a pharmacy school, lecturing, which was a dream for me, and then 3 days at the hospital. So they supported me to rotate to lots of different specialist areas within the hospital. So I got to understand pediatrics from different avenues. We have renal transplant, cardiology, palliative care, gastro, neurodisabilities, lots of metabolic disease. So it's a tertiary center, so very, very specialist. So I was really fortunate to be able to work on loads of different ward areas. And that kind of I gained a lot of experience within general pediatrics. But within that time, I had been there for nearly 4.5 years. I found palliative care during that time. So they didn't have a pharmacist in the palliative care specialty. So they built a job for me. So I was able to work in palliative care in pediatrics and build a role and build a service alongside that, which was something that I really enjoyed.
Oh, wow. And that's hard because I'll tell you, I practiced pre-motherhood for 7 years and then post-motherhood. And my journey was very different. The stories, especially the fatalities or God forbid a child dies when you're, in a code situation or palliative care, you just take it so much more to heart. It's not that I didn't care. I just didn't internalize it and take it home with me as much as I did when you have your own kids, because you just so relate to the caregivers and your heart like literally hurts for them. And so I applaud you for being able to do that, because I'll tell you, one of the driving forces to starting Perfecting Peds was that I was really burnt out from seeing children pass away. Just like after 11 years, took a toll on me emotionally. And so that wasn't the obviously only decision, but one of the many factors that like I want to continue to take care of these kids in a clinical fashion, but I don't think I can be bedside anymore because of how acute and sad this is. So is that your position right now, is palliative care?
Well, I'm in a kind of transition mode. It's long story short. Having 2 kids has been really tough to be a full-time working mom. And the job that I have is in London, and I live far out in the countryside. So it's about 1.5 hour commute each way. So that with a baby at home who is 5 months old, going back to work and sleepless nights, and then trying to be the best version of me became really challenging. So I decided to resign from that post in November because the work-life balance wasn't working for me. And even though it was a job that I absolutely loved, I needed to take a step back and figure out home life first. My son is adorable, but he does not sleep at night. He is...
My daughter doesn't either.
Yeah, so that struggle is real. And it has impacted my energy levels, like my mental health. It's impacted, who I am. So I had to make that transition and decide to work on a more hour by hour basis. So I still work for the pharmacy school, but I just get paid for the work that I do hourly. And I've transitioned to another hospital, which is closer to home, also a pediatric specialist hospital, which is very fortunate.
Perfect. Yeah.
And at the moment, I am working, again, getting paid by hour. And I've stepped away from the patient facing for a little while just to get to grips with home life. But I am hoping to transition back into it.
As a pharmacist, I know firsthand how challenging it can be to maintain our health and well-being whilst caring for others. I am a true believer of making the time to look after my physical, mental, and emotional health, and I love the idea of using natural supplements to support me on this journey. That's why I was so excited to find The Naked Pharmacy. Their products are 100% plant-based and naturally sourced, 100% biodegradable, and it feels really safe to know that they are formulated, tested, and manufactured to the same standard as a pharmaceutical product. However, the most important fact to share is that their CEO and founder, Kevin Levers, is a pharmacist with over 35 years of experience in the pharmaceutical industry. I love that as a community, we can support our pharmacy colleague every time that we purchase a product. As a Pharmacist Diaries listener, you get an exclusive 20% discount off all Naked Pharmacy products using the code PD20. Just visit www.thenakedpharmacy.com and treat yourself to something new.
Oh, well, that's awesome. That's it. But I mean, I relate to you because, as a mom, I felt like when I was full-time in the hospital, because I did that the first 2 years of my youngest child's life, I was miserable. And then I started trying to figure out, how do I get out of this full-time hospital life? And in the interim, somebody asked, have you ever thought of selling skincare? And I'm like, no. And fast forward, I started doing sales in a skincare company, Verdun and Fields. They're in Europe too. But with that, it kind of sparked my entrepreneurial interest. And then it showed me that you can work flexibly and flexible hours, and your work-life balance doesn't have to suck. And so I just thought, I'm a peds pharmacist in the US. My work-life balance has to be crap because that's what everyone's is. And I looked at my colleagues who had left the hospital and saw that they all had to switch to adults, or they had to do what we call medical science liaison in the pharma company. And I couldn't grasp, or I couldn't let completely go of the patient care that I loved. And so, long story short, I started hypothesizing, what if you place a peds pharmacist in the AmCare space, so anywhere outside of the hospital, the four walls of the hospital, and the peds pharmacist, like any other interdisciplinary team member, followed the families and caregivers and worked with their interdisciplinary team anywhere from 7 to 12 times a month. And that was really the preface and hypothesis behind it. And very early on, I saw success. So in London, is it the same thing? Pediatric pharmacists really only practice within the hospital setting mainly?
Yeah, mainly. So we have hospital pharmacists. So some of them would, in the smaller hospitals, you might have only 1 or 2 wards where there would be pediatric patients. Where I work, where they're considered tertiary centers, they're very specialist. Rare is the current hospital I'm at is called Great Ormond Street Hospital. It's very rare diseases that we would come across. So a really specialist niche area of pediatric pharmacy. And the previous hospital was also very similar. But you may find some pharmacists working as specialists in primary care settings, working directly with physicians, maybe running clinics for pediatric patients, but it's very rare at the moment. Yeah.
That's exactly how it is in the US. Like, they're so few and far between. Like, I don't know, I'd be curious in London, but in the United States total, I didn't realize that we're such a limited resources. There's only 1,700 of us in the US. So I wonder, as you go to other countries, if it's the same thing. Whereas, if not a lot of pharmacists niche down into pediatrics for one reason or another, just like you alluded to in the beginning, it's a scary first step because you're like, oh my God, if I make a med error on this tiny human, it's so much more exponential and easier given the weight base to make that error. And I think that scares a lot of pediatric pharmacists regular pharmacists in the US. And then I don't even know what it's like in London, but in the US, pharmacists don't even have access to the child's weight at the time they're dispensing the script, which slowly, state by state, are companies trying to mandate that it's on a prescription outpatient, if it's a big retail or a community pharmacy prior to them dispensing the med, because there's no way they're even checking the dose, let alone the indication, clinical appropriateness, any of that.
Yeah, so if you're going to like a standard retail pharmacy, CVS, Walgreens, that kind of thing, the prescriptions, when they used to be paper-based, they don't necessarily have a weight on it. But the system may offer it, but it wouldn't be up to date. If you are going to an outpatient pharmacy, which is attached to a hospital, then 100% the weight would be on it. We definitely make sure that we have that provision in place. But you're right, the dosages that you might be clinically screening in a retail pharmacy, unless you are kind of asking the parents, it's not like a legal requirement for the prescription.
No, so we got the first state to approve it, which was Ohio, and then I'm working intimately with my state to get it approved. But it's going to be a state by state fight. But in my eyes, like, how are you checking the clinical appropriateness? And the answer is they legally can't or physically can't. There's no way for them to do it. And so it's like scary because it negates the whole purpose of a pharmacist, because our job is to be there as the second check. And if you're not checking anything and you're just dispensing things, the chances of you making a medication error is substantially high. So much so that one of the driving forces behind me starting this company was that I was making a lot of interventions on my own children. Back then I just had two, and they're relatively healthy children. And so the fact that I was constantly intervening on their dose, their frequency, dosage form, because it's not even feasible for a child to take this, like, the reality set in that if you have a medically complex child, the chances of you having non-optimized medications is high.
Yeah. No, and there isn't much focus in pharmacy school on pediatrics. It's still very limited, and that's a work in progress. And we have like a group that's called NPPG. It's the Neonatal and Pediatric Pharmacy Group, which there are several hundred members who are pharmacists as well as pharmacy technicians as well have joined. And we are an amazing community who love and guide and support and engage with each other. We have a conference every year that we enjoy spending time together. Everybody's very keen to do publications and research, education and training, and just figuring out what one hospital's doing and maybe implementing something similar elsewhere and just learning from each other. And I've been really fortunate as part of this podcast journey that last year in November, my husband is a videographer, so he kindly came with me to the conference and we recorded some of the content, created a trailer, made some social media content for them as well. So the podcasting journey is helping me to combine my love of pediatrics with my love of podcasting in two areas. Plus, I get to bring my husband on the journey, which is amazing. And I love spending time with him. And we work so well together. So that's been a really interesting journey. But one of the things that I have noticed is that a lot of the members are from hospital settings, and I think that we need to raise more awareness that people who work in community pharmacy and retail pharmacy are more than welcome to join our community, because they would learn so much and get access to information on a lot of things, like from unlicensed medicines to stock shortages. I mean, we've got so many issues with different types of products no longer being available within the country, or we're really like limited on supplies and we're having to switch patients to different products. And a lot of the patients who require specialist care, whether that's a surgery that they've recently had, or they have medical conditions which like your local physician doesn't really know that much about, especially like if you give the example of palliative care. A primary care physician may only see a palliative care pediatric patient once in their career. So to support that patient's journey, whether they live weeks or months or even years in the community, can be really tough. The types of products that we need to have available, the types of dosages, the constant change in the dosages as well. It's hard to keep up on top of that. And then you send all of that to a retail pharmacy because everything is supplied from your local retail pharmacy instead of the hospital, which could be, 5 hours journey, if not more. So there's a lot of communication that needs to be had with the specialist center, with the hospital pharmacy, with the parents, with the local physician, and with supply issues. We've had a lot of problems over the years. So we want to invite lots of retail pharmacists to come and join our group because they see pediatric prescriptions all the time. And even like your primary care physician, or what we call a GP here, your general practice, someone who's in your local town who you would see for your day-to-day issues. We have pharmacists working there now running clinics. So pharmacists here can become prescribers now. We can run clinics on different specialist areas, which is amazing. And they see pediatric patients all the time as well. So they would gain that support. So part of the role of supporting them with social media is to raise awareness that actually it doesn't need to be a hospital-only member. Anyone within pharmacy who sees pediatric patients can join us.
Yeah, and we have the Pediatric Pharmacists Association here in the States and do a lot of similar things to what you're saying. But yes, just like you, it's mostly hospital pediatric pharmacists. And I think like even the feedback from my LinkedIn posts, people saying like, oh my God, like I learned so much from your posts. I feel more comfortable in pediatrics just from like LinkedIn posts is crazy because similar, it sounds like in the US, it's not mandated that you even have an elective in pediatric or a course. It's an elective. So you have to elect that you have some sort of interest to even learn anything about peds. And then it's totally disproportional because then you go out and practice in a retail or community-based setting and you're like, oh crap, like statistically there's 22% of children in the state or the world. So 22% of your patients are pediatric patients that you have never even had the clinical education on. So it's just so weird that in 2024 all these things are still such a work in progress.
Yeah, absolutely. I mean, we have the hospital that I used to work for. We created our own formulary, a very specific pediatric formulary. Most of the dosages, drugs are unlicensed, but they made that app available for free. So if you're working anywhere in the country or even internationally, you can access that information. And yeah, so when I worked for that hospital, I was part of the formulary team to try and keep that formulary up to date. I mean, things change all the time, right? New evidence might come out, products change in terms of formulation, so you need to just keep that information as accurate and up to date as possible. We have our main resource for kind of medications is called the BNF. It's the British National Formulary, and they've got the children's version. But a lot of the dosages that you would see in retail pharmacy have come from a specialist hospital, which are weird and wonderful, and you wouldn't know where to find those doses. So a lot of people are relying on this app to try and find those dosages.
So our golden standard here in the States is Lexicomp. Do you guys use that or no?
Yeah, sometimes we do. We do
Okay.
use that too.
That's so cool. There's a lot of overlap.
Yeah, definitely. I want to know more about Perfecting Peds. So tell me about the journey of what it started with and its growth as to where it is now. And also, before you get into it, I want to congratulate you on your first official member of staff on your team.
Thank you. Yeah, we have two. Well,
yeah.
Technically, we have two full-time pediatric pharmacists where before we were doing contract-based. So like 1099s where we have 15 pharmacists, but they were doing PRN work or as needed work as contractors, just like you said, hourly pharmacists. But now we have two on staff that are 40 hours a week and dedicated to patient care, projects, operations. And I feel like a weight's been taken off my chest because, technically I'm CEO, but being a tech, when you're a technical founder and you're still early in your journey, you have to do a lot of the kind of not like boots on the ground, work. And so I had my whole process and operations lined up. And so it's nice to be able to like train them and hand them off some of the operations because as we're growing, it's getting harder to keep all the balls in the air. So my journey. So 2.5 years ago, as I alluded to, pediatric pharmacists are almost exclusively in the four walls of large academic hospitals in the States. There's only 1,700 of us. I kept seeing that the continued pattern, worked in Children's Hospital Philly here in Philadelphia, and then an adult hospital, but had a large pediatric hospital within it in New Jersey. And I just kept realizing that there's this repeated pattern that I was always trying to optimize, or I was intervening a lot on the patient's chronic meds. So the patients would come in and I'd do a med rec and I'd be like, what? Like this kid's weight dose hasn't been adjusted and they've like gained significant weight, upward of 30%. So now it's subtherapeutic. Or when I'd ask, what is this med for? The mom didn't know. The primary care didn't know. They were just like, I don't know. Like it's been on for years. So I just continued it. And they'd be giving routes, like, for example, using the jejunum, like a jejunal tube, but it's not even absorbed in the jejunum. So it was just like constantly, and I'm like, what is happening? So after 10 years of seeing the problem, I was like, why is this occurring? And so doing a root cause analysis, for lack of a better word, you have in the US your pediatricians, or as you call them, GPs, and they only have one semester of pharmacology, and they come out in residency, as you know, being a part of the hospital. Naturally as a pharmacist, you're kind of adopting the medical residents and teaching them pharmacology along the way. And I realized that they're strong in like their core general pediatric medications, but once you start adding these specialty medications, they're lost. And they actually will openly tell you, I'm not intervening on a specialist meds, even if I see a med error, because it's like, I'm just not comfortable. So you have this very hands-off approach of a pediatrician, which I understand. It's like, it's pulmonologist specialty, it's the neurologist, and then you have your retail pharmacist, as we just talked about, which in the US, and it sounds like in Europe, maybe in London, that they don't equip or pharmacists in general with enough pediatric resources or just clinical experience, or and with that, there's just these like gaping holes in these pediatric care when it comes to medication management. And so I then started to do, all right, we have the problem. I know why it's a problem. Now, how can I fix it? And so I started locally in New Jersey. We have these things called pediatric long-term care facilities where you may have in your palliative care experience come across them. I don't know if you guys have them, but they're basically, you have patients, pediatric patients that are so critical and have high acuity. They have G-tubes, trachs. They're on 20 plus meds that live in these facilities all year round. And they're really never discharged until they age out into adulthood. We also have these things called medical daycares where, if a child of medical complexity needs childcare, they go to these medical daycares and they have licensed RNs to administer the meds. So I knew that a lot of our children of medical complexities, and the reason why I focused on them is they were really like the low-hanging fruit, because you think of who would need our help the most is someone that has a lot of medications, right? Just intuitively, that exponentially increases your risk of having medication errors. And so I went door to door. I told you I sold skincare. So I had a little bit of the sales girl in me. And I learned, as weird as it sounds, I quickly became like one of the top salesmen at this care company and realized, hey, I like sales. Like, I feel like we use it as a dirty word, but like, if you're selling something you're passionate about, it doesn't really feel like sales. It's just like, hey, I have this really cool thing I want to share with you. Learned a lot about mindset, about team building, a lot of things that like we don't get in pharmacy school that if I had to do it again, I would hands down be a sales rep again. So that being said, with all that, I went to various facilities here in New Jersey that traditionally didn't have a pediatric pharmacist, never had a pediatric pharmacist, were considered AmCare and said like, hey, just pay me peanuts and we can do a value-based care contract at the end of this bad boy and see how much me and my team saved. So I had no idea what the hell I was doing, but I knew I could take really good care of these children. And so I was dropped like over 300 in a very short time frame, in a month. And these children had an average of 23 meds on these profile, trach, vent, G-tube dependent. I don't know about you guys, but in the US, pharmacists are really poor at showing our worth, like objectively showing our worth. And so I knew like, if I'm going to do this and it's the first time ever it's being done in the US, I have to get really good pharmacoeconomics and research behind it. So we did that. We took our first 102 patients and we studied them. And actually today, I'm going to post on LinkedIn after. The journal article gets published in the Journal of Pediatric Pharmacology and Therapeutics. And we were able to prove things that like you and I know as pediatric pharmacists, which is a 15% reduction in unnecessary meds, 44% reduction in hospital readmissions, and a 1.1 million cost savings and cost avoidance in just 102 of these children. I realized that I'm really good clinical and I'm really good in operations, but I don't have the business sales strategy brain. And so I then put a beacon out into the universe and got a business partner. And I've been with him for a year, and he was able to take our model from predominantly, we also have like contracts, what we call here collaborative practice agreements in Minnesota in various different clinics, just as you're saying. But we kind of flipped it and thought, okay, what if we go to insurance companies? These are the ones that in the grand scheme of thing are saving the most money. And so we pitched to a bunch of healthcare plans. We were able to close and contract with them in less than 4 months, which in the United States is like a small miracle. We started with them last month, and then we have 3 other insurance companies in all different lines of business in all different states that we contract with. And how it works is, I'll finish this and then I'll take a breath, is we partner with the insurance companies. We give them our risk stratification score. They distill down who are their sickest children, who need us the most. We then partner with the caregivers and the whole interdisciplinary team. And we see these kids 7 times proactively throughout the year and provide comprehensive med management, and then 5 reactive. So whether that's like admission, discharge, or transfer, addition of a new meta and change of social determinants of health. So really, that's where I wanted my model to be 2.5 years ago, but I had to start somewhere. And it's, how do I get to almost, as audacious as it sounds, every child that has 5 or more meds, how do we get them with a pediatric pharmacist, just like we would a general practitioner or a pediatrician? They have as the standard of care, dietitians, OT, PT, but you never see the pharmacist in that model. And so that's what I'm set out to change. And I know that was a really long-winded answer.
It's a great answer, a very detailed answer that we needed so we can understand what's been happening in the story. That is incredible. And congratulations for your publication. That is a very exciting achievement.
Thank you.
And one that we get to share today on the podcast, which is incredible. I'm so happy about that. And I'm proud of you. That's a really exciting journey to be on.
Thank you.
And it's really interesting because it's very different to the UK, because our health service, our National Health Service, is technically it's free because we pay for it through our taxes. But if we see a physician, a nurse, or go to a hospital, vaccinations, appointments, like, it's all free. We don't pay for anything in the way that private healthcare and insurance works in the UK. So it's a very different experience. There are positives and negatives of both places. One of the major negatives that we face here is that things are a little bit slow. Things take a lot more time. Wait lists are longer to get surgeries, as an example, or get a referral to a specialist pediatric doctor, versus if you had good insurance cover and you were in the US, you could immediately book an appointment with a clinic, using that coverage, which works really, really well. So there are some disadvantages, but when you look at the impact, I think, that pediatric pharmacists make here in the UK, and how much value we offer, and how much the physicians rely on us and value our worth and want us to be part of their multidisciplinary team, we're in. We are absolutely 100% in. We are making some amazing changes to pediatric care here in the UK from that perspective. And I worked at the Evelina London Children's Hospital. I think it's around 250 beds, maybe 300 now. The pharmacy team is 40. Each ward would have at least 1 to 2 pharmacists who are pretty much there all day. You are doing drug histories, meds recs, you're making interventions, going on ward rounds, you're part of multidisciplinary team meetings with very, very complex patients, like you said, with potentially up to 20 meds. And the impact that we make is incredible. There's so much research that we're doing here. But one thing that was different to, I think, what you were saying with the US is that our parents know so much about medicines. Our parents are insanely knowledgeable about their children's medicines, routes, how they administer, taking responsibility for the care of their children. They teach me so much on a day-to-day basis if I'm on a ward. There are so many moments where I don't know much about a drug, and the parent is genuinely teaching me on the journey, because they have learnt so much having a child with such complex conditions. Children themselves have taught me so much. Our renal transplant patients are the cutest. There are 4-year-olds who know more about medicines than, the average adult who is taking 5 or 6 medicines. They know the names, what colors the medicines are, what time they have to take them, with or after food. They know so much about their medications. And it's interesting to see the differences between our countries, but at the same time, it's nice to see the similarities as well, right?
Yeah, I think there's a lot of similarities. Just like you're saying, in the hospital, which you're talking about the ward, which we call a hospital floor. But in the ward, we are used day in, day out. Like, we are indispensable. My hypothesis was, why aren't we in the community, and why aren't we indispensable in the community as opposed to the hospital? So you think of the amount of time you spend a child spends in a hospital is completely negligible compared to the time they're in the AmCare space. And just like you're saying, these caregivers are almost expected to be the quarterback of their medications and be able to navigate for us, which is like insurance approvals. We're supposed to know like the routes, the frequency, the dose. But then in the US, I feel like there's this burden of like, they're even supposed to know a lot about the medications, given that they see how frequently children are burned and medication errors are happening because, again, as I alluded to in the beginning, there's no pediatric pharmacists looking holistically at their meds in the ambulatory or outpatient setting. And so that's obviously where Perfecting Peds shines now, which historically there's been no one in the community really from a trained eye and a pharmacist expertise looking at these med regimens.
So how does it work in terms of the operational side? Are these virtual conversations that you have with families?
Yeah. So just like you said,
Amazing.
The caregivers know it. They a lot of times know more than we as providers know about their medically complex children. So we hook up with them virtually. We have pharmacists like that are, I'm in New Jersey, but I see patients in Minnesota because I'm licensed in Minnesota. So we can see patients in other states. Do you guys call them provinces, right?
Counties.
Counties. Okay. Counties. But we can see them just by virtually. And then we have contracts with the payers or the insurance that says we're allowed to bill for our services. And that's relatively new. Just like you talked about in the UK, pharmacists being providers, that's something that's happening slowly on a state-by-state basis. So we strategically pick the states where pharmacists have autonomy and are recognized as providers. For example, where I'm at in New Jersey, I had to rely on the facilities paying me money. And so now that we're kind of flipping it with the payers, we're doing states that pharmacists are recognized as providers. And it's kind of crappy. We're just like going state by state. Like if you're provider status, your child gets great comprehensive med management in this state. But if another, like where I live, where they have no provider status, no billing rights, really anything, we can't give the services out. So it's kind of wild. And for many reasons, that's where I feel like the UK and the US differ.
Interesting. So you have these virtual conversations. You want to make changes to the patient's medications, whether you might consider stopping a medication, changing a formulation, changing the time of day, maybe offering a different solution.
Mm-hmm.
You then have to go back and liaise with the physician to actually write the prescription.
Yeah, so we have actually two different models to thoroughly confuse you. We have the collaborative practice agreements where our team is embedded virtually into clinics. So we have 6 various sites where we're partnered up with a provider and we have a collaborative practice agreement, meaning that we can do a lot of things without the provider giving live acceptance. We can write a note, and then anything that is a little bit more like outside of a mid-level, like, okay, I want to wean this med, I want to take off this anti-epileptic, I want to order more blood work. Depending on the physician's comfort, we can do a lot of those things. Now that we're also insurance facing, one of the things that we find is just like you're saying, we don't have the autonomy of a collaborative practice agreement. So we do have to do a lot of that liaison work. And so we've hired care coordinators who help us do some of the liaison work. And then we've also automated technology where we're able to inbox the providers of almost any EHR, and it will tell them, hey, this is who we are. Here's what we recommend. Can you give us a call? We're even doing things like faxing physicians, old school, just to get the word out that here's who we are. The more established you get and the more physicians that know we're available, the easier it is. But when we call a physician or message them the first time, they're like, who the heck's Perfecting Peds? Like, what are you talking about? So it's getting easier and easier as we build the outpatient rapport with clinicians and physicians and nurses and dietitians. But, each state we're getting more recognized. But again, we're going to have to kind of like state by state attack this to get them to know who is Perfecting Peds and that we offer these services and partner up with insurance companies.
That's interesting. I mean, we're really fortunate now in the UK that we've become prescribers. So
that's amazing.
So once you're qualified, usually you would have been in your role for, it changes and it does vary on your experience, but say 3 to 5 years you've been qualified, you would then apply to become a prescriber, and it takes 6 to 9 months, depending on which kind of university that you do it with. Mine was 9 months. And you do it within a specialist area. So I did pediatrics, but I did it specifically, obviously, in palliative care. And your scope of practice usually starts with a really small kind of area of expertise, like 5 or 6 medications. And then once you're qualified, you can technically prescribe anything that you want. Once you get the qualification, you can technically do that. But in terms of competence, a lot of people start small and then build up their expertise and increase the number of medications or the types of medications that they want. So for me, on a symptom management plan, I focused mainly on dyspnea and anxiety. So I'm prescribing drugs like morphine, midazolam, chloral hydrate. And part of building my role was that a lot of palliative care patients are in the community. We see some, obviously, in the hospital, the acute situations, which I have a huge impact on those families in the moment. But most of our population are at home, right? And the doctors that I work with, the consultants, as well as the nurses, would do loads and loads of home visits. And our patients live all over kind of the country because we're such a specialist hospital that people would travel to us, right? So in our local area or within sort of an hour and a half, 2 hours travel, all of our doctors would travel around to go and do home visits every kind of 3 to 6 months, but they never had a pharmacist join them. And when I was in my training, I would go and join them and just learn. I was absorbing information. My role was to absorb and learn. But because I was there, they would always include me in the conversation. And when it came to medicines optimization, we realized how much knowledge I had as a pharmacist and how much impact I was making on those families just in my kind of like training time. So the plan, which is so unfortunate that I've left the job, but the plan was to then set up virtual clinics for medicines optimization for patients who are quite stable, because that would be an area of competence that I would be happy with. Maybe children who were above the age of 1 who only needed like a yearly review or a 6-monthly review. We would review all the medications with the parents and try and optimize them, and then liaise with the local physician and the local community pharmacy for supplies. So that is happening now. Obviously, someone else is in the position and they are building that, and they've just started the job. But that was kind of my plan in terms of building the service within the palliative care team, which was a really exciting journey to be part of. But I am not unique. There are lots of pharmacists who are doing that across the country in different areas of expertise. So it's really interesting to see how Perfecting Peds is working from that point of view. We have so many interesting similarities. It's just the insurance perspective that's very bipolar opposites. But in terms of what the pharmacist is actually aiming to do, it's very similar. So I'm super interested to hear more about this off the podcast.
Yeah, same.
And to make some introductions for you to come and meet people that are in my network who would love to hear more about Perfecting Peds too.
Cool. I would love that.
Um,
We're going to the UK, baby.
yeah,
I
yeah,
think
yeah.
it would be
Let's
so
do it.
cool. I love it.
Yeah, because Todd Uri, when I joined the Pharmacy Podcast Network, I was the first international podcast host.
How cool.
And yeah, so it's I feel like there are connections that are being made between me and people in the US through this podcast, which are really exciting. So that was kind of like the first thing in terms of international growth. So yeah, cheers to making the UK the first place that potentially Perfecting Peds gets to support on a global scale.
That's awesome. And it is really cool to see. And I'm inspired to see that like you guys are able to prescribe. Because I think eventually it would be awesome for us to do the same because we have so much education. Like,
I know.
and then you add our education, our residency, our board. Do you guys do board certifications in?
No, but we just have different types of training, but it's
Okay.
not exactly the same as a board certification. But yeah.
But I mean, we do that. Then we practice for 12 years and so like not to sound snobby because I'm talking from to one pediatric pharmacist to another, but I'll have like a caregiver call or whatever, or consult us formally, and they're like, "Hey, the prescriber gave me X, Y, and Z." Like literally 2 days ago, ceftonir for a UTI, and I'm like, "Well, that doesn't penetrate into the urine, so that's definitely not a good antibiotic." For a UTI. And then I was like, "Can you tell me what's growing?" They're like, "Kleb pneumo." I'm like, "Okay." And they're like, "And also Enterobacter." And I'm like, "Well, the ceftonir's not gonna treat that." And so Claraceae. So it's those types of things where I'm like, we're pretty good. If you give us the diagnosis or, we're reading a culture, I mean, we're good. So there's like a lot of, so it's really cool to see that you guys have come even farther in practice in the UK where you guys can prescribe. That's amazing.
Yeah, we're working towards all pharmacy students who graduate will end up being prescribers in the next kind of few years. We're working towards that transition. It's a little bit of a scary transition
Of
because
course.
it's a big responsibility for someone who's just graduated. But it's a work in progress, and we're excited about it in the country in general. But obviously, we have some reservations because it's quite scary. I mean, even now to this day, if I still have reservations sometimes when I would put pen to paper and write a prescription, right? I'm not doing it as often as I'd like. And currently I'm not patient facing. So you get out of practice, right? And your confidence levels change. So for a newly qualified pharmacist who doesn't have, like me, 13 years of experience, it's definitely going to be quite scary for them to take on that responsibility. But we're hoping that this is really going to support the general healthcare setting. The fact that pharmacists can prescribe in different areas of practice will reduce the burden on so many doctors around the country in so many different areas, not just peds, but in adults as well, which is super cool. And we're all kind of looking forward to that. When it comes to Perfecting Peds, what are your kind of goals for the next kind of year or two in terms of growth or development, or what are you kind of thinking about in terms of ideas?
Yeah, so we're in the fun startup land of I don't know if you guys in the UK venture back funding, which is basically you're funded by somebody so that we can really build out our technology. We can hire clinical pharmacists more full time to support our contracts. We could get more sale, like a more polished. Right now we have one person doing sales and me as a CEO, and so just opening the opportunity for more growth, which is super exciting. So with that funding, that will enable us to scale, to take more contracts, and ultimately at the end of the day, as a clinician, always at heart before any sort of executive level, I want to see us take care of as many children as possible. And so some of the unanticipated, exciting things besides, delivering medication therapy management or comprehensive medication management to these children has been like, we've been able to formally start taking, in 2 months, start taking advanced practice pharmacy students where they can come and do formal rotations with us. It's really exciting because like some of these students, based off of the school they were on, may not even have had the opportunity to do this. And so I want to build our program so eventually, obviously, we're taking pharmacy students. In 3 years, I would love to say, okay, we're residency. We can take students right out of school and do residency. I really just want to open up the opportunities for more clinicians, whether they're seasoned and they've been in adults for a million years and they're like, I really would love to do pediatrics, for them to be able to switch and do peds and use the technology that we're building in the clinical pathways so that we can plug in a less senior pharmacist and they would feel comfortable starting to navigate the pediatric pharmacy terrain, and then hopefully also build more pharmacists coming out of schools. Because like we already alluded to, that pediatric training's not really supported in our current universities.
No, it's really exciting to see the kind of opportunities for growth for the younger professionals coming out of pharmacy school, and just those opportunities to get involved with pediatrics and not just go down the traditional residency pathway and getting that board certification. You're opening up their eyes to see, hey, what does pediatrics actually have to offer, and what could you enjoy on this journey? If you're a student and you come and do a placement with us, you can see what peds is all about. And I think that exposure is going to be great for them.
Yeah, I'm excited. I don't think you realize till years later, like how much your mentors affect your every decision. So if we can like find, pharmacy students that are really gung-ho about pharmacy, it seems like a win for us as far as we're able to use their talents and they can help us do research and all these things. And then for them too, they'll get, I would argue a lot of our pharmacists are way smarter than I am, but also they get to learn a ton clinically. So I'm super excited about those unanticipated opportunities.
Amazing. Before I let you go, where can people find you and Perfecting Peds?
They can find me. So perfectingpeds.com. We just had it redone, so I'm super excited about that, the website. And then also I'm very active on LinkedIn, as you are, Jena, Jena Quinn, Quinn.
Perfect. So I will make sure that I put all of your links into the show notes for the episode so people can connect, find you, find out more about Perfecting Peds. Thank you so much for coming onto the podcast. It was such a pleasure to actually get to know you.
Same.
And learn more about your journey and what adventures that you've been going on in the world of children.
Thank you. Same to you.